Perfect. I would like to call this work session to order. With work sessions, it's just discussion. There is not going to be any decisions made tonight. We are going to be discussing substance abuse and homelessness. With that, I want to start off. We'll do introduction. We'll go this way. My name is Justin Rock, and I'm the mayor of LeGrand.
David Glade, I'm on the council.
Corinne Duda on the council.
Chris Andrea, Recreation Coordinator.
Stu Spence, Parks and Recreation Director.
Molly King, Council.
Fraser Keel, Housing Services Coordinator.
Danielle Bechtel, Center for Human Development.
Brooke Taylor, Center for Human Development.
Jason Hayes, for the first time publicly, Chief of Police.
Cody Bowen, Union County Sheriff.
Ricky Joe-Hickey, Counselor.
Mary Ann Wiesner, Counselor.
John O'Brien, City Manager.
Perfect. And with that, I will turn it over to the chief, and he will get us going.
All right, well, thank you. Thank you, councilors, city manager, mayor, recorder, media, special guests. So you had to pick like the huge societal problem topics for me, but I'm glad, and I want to make this worth your time. And really, in your packet, you will have some bullet points that I'm going to go through A through Z quickly, but these are to trigger the discussion so that this is meaningful for you. And another approach that I had is I wanted this to be systematic, not what is Jason Hayes saying about these big topics, but other community members. Chris, Frederick, Danielle, Brooke, Cody are all special guests that I've asked to come that can speak on their specialties in regards to substance abuse, homelessness, and wrapped in that is also mental health because they're intertwined. So if you'll indulge with me, I'm just going to go through this quickly to give you some ideas. So community overview. LeGrand, like many Oregon communities, faces ongoing challenges related to substance abuse, mental health crisis, and homelessness. These are societal issues. These issues are interconnected and create sustained pressure on law enforcement, dispatch services, hospital systems, behavioral health providers, and the jail. And there's many more as well. Drug addiction, untreated mental illness, and homelessness often exist in a cyclical pattern that is difficult to break without coordinated intervention. Interagency collaboration. So the LeGrand Police Department works closely with the District Attorney's Office, CHD, Oregon Center on Behavioral Health, the Behavioral Health Union County Multidisciplinary Team, Right Track Resource Center, Union County Sheriff's Office, Oregon State Police, and other community organizations in addressing these community concerns. These partnerships are critical in addressing crisis response, treatment access, enforcement, and long-term stabilization efforts. Mental health and suicide data for, this is just the city of LeGrand for 2025. We had 462 mental health related calls for service. That is where the root cause is a mental health disorder or issue. That is a 12% decrease from 2024. When I ran that number, I was optimistic until I ran January statistics, and we had 69 mental health related calls just in January of 2026 alone. 149 suicide related calls in 2025 reflecting the severity of the crisis. Calls are often complex, repetitive, time intensive, and carry increased safety risks. The homelessness, and you will see the words interchanged. I was corrected. So homelessness and houseless. Moving forward, I prefer that we use houseless because you can say you're from LeGrand and that's your home, but be houseless. So if you see those interchanged, that's why you would see a name change in that. So 149 calls for service related to houselessness, 25% decrease from 2024. Most of those calls are the ones people sleeping in the lobbies, on the sidewalks, under the overpasses. And now we're starting to see a trend more in their vehicles. Many contacts involve individuals suffering from substance abuse and mental illness, and a lot of times it's a combination of both. High housing costs and compliance challenges limit long-term solutions. And when I say compliance challenges, there's often people who are suffering from these disabilities who get placed into housing, but they can't follow the rules. and they get evictions. I asked the school district, they have 68 students in the LaGrange School District who are experiencing houselessness. And some of them may live in motels, RVs, but that is houseless. Drug activity and overdoses for LaGrange in 2025, we had 41 overdose calls reported to dispatch. And the methamphetamine and fentanyl just show what the current trends are. Methamphetamine continues to be the drug of choice in LaGrange. Fentanyl had its hit, but we're starting to see it decline. I think it's because of the high risk, safety risk to the people who have addiction issues and the overdose rate associated with that. Drug addiction continues to drive crime, instability, and health emergencies. State level barriers. Oregon legislation prioritizes civil rights before public safety. We could get into examples on that, but really what that means is that mental health treatment and drug treatment is largely voluntary. And our experts here on the panel can talk a little bit about that. High criteria for involuntary commitment. We have limited bed space. And so the bar to involuntarily place somebody is very high. I did a study on this, but I could really get in the weeds on that. But for tonight, I want to be respectful of your time. Limited mental health bed space. Oregon ranks among the worst nationally for mental health access, suicide rates, and addiction rates involving fentanyl and methamphetamine. So you can see that this is not just a problem in LaGrange, this is statewide. System and justice limitations, limited tools to address criminal behavior rooted in untreated mental illness. Civil commitment mapping workshops that we're a part of have produced limited measurable outcomes. Jail is often the default option when other systems lack capacity. And police departments are largely limited to short-term Band-Aid interventions such as arrests, citations, or temporary removals, while durable, long-term solutions to substance abuse, homelessness, and mental health crisis require comprehensive legislative reform, sustained public funding, and coordinated social service systems beyond the scope of law enforcement authority. That's a lot to digest right there, I'm sorry. Operational impact on LaGrange Police Department, significant officer and dispatch time spent on crisis mitigation and de-escalation, repetitive calls for service involving the same individuals, increased safety risk due to unpredictability of mental health crisis, and resource strain limits proactive policing efforts. I know that drug enforcement has came up. So proactive drug enforcement as a strategy, although it in itself is not a fix-all, it can prevent overdoses and disrupt drug supply chains, provide accountability for users and dealers, create pathways to drug court and treatment programs, and reduce street crimes associated with drug use and distribution. Barriers to drug investigations, the number one is limited staffing and funding, advanced investigative requirements and high liability, specialized training in informant management, surveillance, operational planning, in search and seizure law, need for multiple detectives to conduct effective investigations, increased operational costs such as equipment, vehicles, training, and personnel. And Union County is not a high-intensity drug trafficking area, which limits access to federal resources. Detectives frequently reassigned to patrol due to staffing shortages. Alternative enforcement approaches, there are things that patrol officers can do through buy-bust operations, traffic interdiction, surveillance operations, informant-based investigations, collaboration among criminal and street detectives. Recruitment and retention challenges, staffing shortages at the LaGrange Police Department and the District Attorney's Office, significant caseload and case backlogs with delays lasting years. This is mostly at the DA's office. We have drug investigations where we've made an arrest that have not been dealt with in 2 years now. Staffing limitations within the LaGrange Police Department currently restrict the ability to conduct proactive drug investigations. Adding 2 additional officers would enable more focused drug enforcement efforts, increased capacity to connect individuals in crisis with appropriate services, and strengthen the department's overall long-term ability to serve the community. The LaGrange Police Department is partnering with the Union County Sheriff's Office and Center for Human Development to pursue grant funding options for a community service officer position, which would be a non-sworn LaGrange Police Department employee dedicated to providing resource referrals and one-on-one support to houseless individuals and those in crisis, therefore freeing sworn officers to focus on education, prevention, and other enforcement efforts. Demonstrating a sustained commitment to proactive drug investigations will strengthen the LaGrange Police Department's ability to build collaborative partnerships with the Union County Sheriff's Office and the Oregon State Police, enhancing coordinated enforcement efforts across jurisdictions. That's a lot, and I apologize, but those are hopefully trigger some Q&A from you. And I think what I would like to do is just start with special guest Sheriff Cody Bowen, and then we'll move around special guests and add their input, and then open it up to you, the council, for questions.
Thanks, Jason. In a nutshell, I try and keep things as simple. This is so much depth and so much detail on each one of those bullet points. Bottom line is Oregon has a mental health addiction crisis. And we have dug this hole, and I say we, as a state, we have created this problem. And we can go back and argue one way or the other, but Oregon has created this problem and enabled this problem, and now we are so deep, like he says, we are the nation's worst state when it comes to mental health and addiction services. We're just the flat bottom of the pool. That really inhibits our ability as law enforcement to hold these people accountable when he, especially when he says, you know, we have cases that are 2 years old. Some of them are even close to 3 years old now. And to nobody's fault other than the cases just haven't been prosecuted, the people haven't been held accountable. However, that being said, even if those folks are being held accountable, to what level of accountability are we talking here? Because we have, I don't say the majority, but the majority of the folks that we deal with are repeat offenders over and over and over and over again. And then when we get to the mental health stuff, we have no options in Union County, period. We have absolutely, I mean, CHG, God bless them, they do the best job they possibly can from 8 to 5, Monday through Friday, and they've done a lot of good things in our community. But we have no treatment centers, we have no stabilization, we have no residential beds that these folks can receive the treatment they need and fix this problem. And I'll tell you, even if we did, I don't know that we would see a huge thing, because you have to be willing to change. You have to recognize you have the problem. You have to commit yourself to this program of recovery. And we see very few folks in our community that sit on that it's a pedestal really of being in recovery and being successful and taking those other folks under their wing. And they do so, Brooke especially, I've seen her, you know, for the last few years, try to get these folks into recovery, and they have very limited options on what they can do. And when that person decides that, hey, right now I'm ready to go, we need to be able to provide them something right now. They're ready to go, load them in the truck and take them to a treatment or a stabilization to get the detox started, to get them somewhere. And we don't have that, flat don't have that in Union County. So what happens is they end up going to the hospital, and then they end up going into the jail. And everybody knows the jail is not a treatment facility. We do really good work with CHD. They come in, they have counseling services, they have mentor services, and they try their best to provide that service. But it's very frustrating for us. It's very difficult. 6 or 7 of our beds are usually filled up with a mental health situation that we have people in there that should not be in jail. They have no criminal history, have no criminal record. They just had a crisis, and no resources to direct them or no place else to put them other than in jail. And that's unacceptable. So I think what my excitement about being here is just brainstorming this with everybody and seeing what we can do on a local level, because I don't have a lot of faith in our state, and I don't like relying on our state. And if there's stuff that we can do here to move the needle, I want to be a part of that.
Thank you, Sheriff.
Sure. I would like to piggyback off that. My main role at CHD is the substance use disorder coordinator. So myself and my team do a lot of outreach, and our resources are limited. If we have somebody that we haven't been able to get in contact with because they have no phone and they're houseless, and they come in on a Friday at 3 o'clock and want help, and they, at that point, are ready, whatever the case may be, We have to tell them, I hope you can make it through the weekend. A majority of the time. Our closest medical detox, which is what is needed for fentanyl and alcohol and benzodiazepines, is 45 minutes away. And it's really hard to get somebody in there on a Friday. The weather right now, it's hit and miss. If we can't get them in there, they have to go over to the coast, which we don't have the resources to be able to have one of our people take them. And then medical transport is a whole nother mess. We just don't have the resources, and it's getting worse out there. And we have our crisis team that goes to the hospital. We have our jail diversion that goes into the jail, and they're amazing. We do have our outreach center from 12 to 4 Monday through Friday. We coordinate awesome with the Right Track Resource Center and other partners. Like Sheriff Bowen said, it's just a crisis. It's not getting better. If we have resources closer, that's not going to bring substances into our county. It's going to allow us to help and build that bridge that so many people need to be able to actually have stabilization, to get their feet back under them and do something that is able to work and want to put in the effort, with closer mentors and access to CHD services and all that, instead of going out of county and coming back and getting lost in the shuffle of things. Yeah. And on the note of criminal charges, that, you know, I also sit on the Union County Treatment Court panel. And it's been a rough couple years getting people in there, and I've seen that program work for a lot of people. And it has huge benefits, but.
You said it's hard to get people in there?
Yeah, just, I don't know, I'm not gonna pretend to know how the whole thing works with the legal side and
Oh,
that,
gotcha.
you know, but just having the people be ready and willing to accept that offer, because it takes so long for all the other pieces to,
Come together.
yeah.
Is that part of the drug court?
Yes,
Okay, so it's now called treatment court instead of drug court?
there's
Or there's two?
There's drug court,
Okay,
which is what I call it, treatment court, drug
Okay.
court, and then there's behavioral health court.
Okay.
So that's for the mental health
okay.
side. I sit on for the
The-
drug side.
Okay, thank you.
I think that's all I got. Don't like being put on the spot.
Well, thank you.
I'll put you on the spot.
I want even more. So I have to 100% agree with Chief Hayes. This is a huge topic, and it's one that we focus on a lot. My role at Center for Human Development is I'm one of the clinical supervisors that oversees all of the adult programs, and I'm also one of the interim behavioral health directors. So it's brought up on a daily basis, and as an agency, we're trying to find solutions, but as Sheriff had pointed out, there's really not a whole lot locally that we can offer. We don't have the treatment centers available. As Brooke pointed out, the closest one is 45 minutes away, and we tend to have to transport even further. Medical transportation is a great resource, but it's not always available. They need 24 hours notice ahead of time, so normally what we have to do is I pull one of my staff to go do the transport, which isn't the best option, but it's what we have. We don't really have many sober living home availability. A lot of them are really full, so that's putting out some of those clients that are houseless out further. And I know that Right Track and Neon have different resources at this point, but usually it doesn't. It's not an immediate fix. There's a Band-Aid that we're putting on. So we do have the crisis team, as they both mentioned, that does work 24/7. And, you know, they try the best they can, but we can't make anybody enter into treatment, whether it's mental health or addictions. We can do, go towards civil commitment, but as Chief Hayes pointed out, there's a lot of legalities that go along with that, and we may agree, but the courts may have a different perspective on it. I could keep going on, but I'll turn it over.
I agree with everything that's been said so far. It really is a crisis. I've been with the Resource Center for about a year and a half now. And even when I was with Child Welfare or like Baker Women's up in Baker as a drug and alcohol counselor, I've learned more and more of how difficult the situation is. The Resource Center, my role is the Housing and Services Coordinator. I help people with community service. I recruit and train volunteers. We are only open if we get enough volunteers through the winter season for overnight shelter. There are no shelters except for like 45 plus minutes away. So in terms of a place for people to stay, this is the only option. We also provide showers and all those other like meaningful things that people have a right to, like laundry and like, you know, being able to shave, getting a food box. And it's really important when it comes to mental health because it's hard to have good mental health and you can't shower, you can't shave, you can't sleep without worrying about someone stealing your stuff and stuff. And we see a lot of people. This year we've had 109 individuals come through so far. That's not saying that's all the houseless people in LeGrand. There's probably more. But we see a lot of people and we handhold quite a bit. We've housed 8 people, whether that's Oxford houses, an apartment, detox, but it's a lot and we're overworked. We have short staffing, it's just me and Maggie. And it's just us, and it takes a lot. And we also are low on funding. We have some part-time staff, which has helped the overnight shelter, which has helped people be more stable and get those applications in for a job, get those housing applications in, be able to shower and find work and stuff, but it's very difficult and we definitely need help. We're doing good things, but yeah, if we all come together, I think we could get more accomplished. And other than that, it takes time. It takes a long time, a lot of hand-holding. A lot of the people we work with, they've suffered trauma, at least mental illness, and I don't know if any of you have done therapy, but it takes months, sometimes years, to work through trauma. And then it takes time to get over the substance use, which is used to cover up that trauma and emotional dysregulation. And then after that, then you can start looking at stability when you do get into an impairment. But yeah, I think that's it. It's doable. It's not all doom and gloom.
Thank you.
I'll just set Chris up if you don't mind, Chief.
Yeah, please.
So just want to talk about the other side, which is prevention, right? We're talking about treatment, we're talking about resources, but a key component that we're involved with in Parks and Recreation and also through the Union County Safe Communities Coalition, the sheriff, the chief, Councilor Dudo, and others around the table, the CHD partners, the health, all the things, right, are part of this. And the challenge is to address youth before they get to this point, right? So I think it's a valuable part of the conversation to also reflect on the things that we're doing to build these kids up and give them skills that create resilience and maybe some prevention efforts, not only through the Safe Communities Coalition efforts in education in schools, but also through some of the things we do. So go ahead, Chris.
You know, collaboration is huge, and like Stu said, you know, we're more on side of the prevention, right? We're not where you all are, but it's key, right? You know, there's lots of risk factors, and trauma's a big one, and having come from a lot of trauma myself, you know, having the programs that we offer, like safe places like after school program, our summer camps, it allows kids to develop, we prevent things by allowing safe spaces, mentorship from, you know, a lot of my staff are college students, volunteers that work within our programs, or volunteer coaches that work in our youth sports programs that can make an impact, caring adults, right, respected peers. It builds a sense of community for the kids. It builds a sense of self-esteem through our programs. And those are all super important protective factors to prevent going down the abuse and mental health. Is it going to solve everything? Is it the one-all fix-all? No, but it's a start, and it's just a ladder process where I think our programs can really help, and we reach a lot of kids, and we have low cost for that reason, so we can reach more. And I think it's, you know, it's part of the process, and so it's good that we have that, and it's great that we have these other resources, but more is always better. So.
Questions?
I had a couple when you were talking, and then one of them was, I was just wondering, when you were saying, here, the repetitive calls for service from the same individuals.
Yeah.
Has that decreased, increased?
No, increased.
It has.
Let me give you a perfect
Okay.
example. Thank you. So I'll try to move quickly through this. We're talking about mental health. So I did a study and I tried to identify why are we dealing with this now, but early in my career we did not. And here's why. And this is a brief narrative of that. But I worked with CHD, Dwight Dill, who was the director of behavioral health at the time. So prior to around 2007, we had we had more money towards this, and we had acute psychiatric centers, and we had one in Pendleton. And the bar to get somebody involuntarily placed was inability to care. That was a low threshold. So the police would go deal with somebody, determine that they're having a crisis. We would call the mobile crisis team from CHD. They would come out, and on one time, they could involuntarily place somebody in the acute psychiatric, and long enough to get them restabilized, get them back on their medicines, get them showered, clean, dignity, and then they would be reintroduced into the society, and we wouldn't have these ongoing problems. What happened? The funding went away. So what happens? The acute psychiatric centers went away, and so you had very limited mental health bed space in the state of Oregon. So you have all the communities vying for very few beds. The state couldn't match that burden. So what they did is they changed the bar in which it takes to involuntarily place somebody. The bar now is you must pose a serious threat to yourself or others. Ninth Circuit Court has determined that that is an extremely high bar because we are a civil rights state. So what happens is we deal with the same person over and over and over until they decompensate so badly that CHD then has enough tangibles to involuntarily place them. Because these people do not seek voluntary service for the most part. The ones that do are not the ones that we deal with. Here is why the system's broken. We dealt with somebody 2 weeks ago 16 times in one day. And what happens is we go, we de-escalate, we mitigate. These are not criminals. These are people who are experiencing a crisis. We call CHD. If they have the staffing, they send somebody out, but they're just like us and everybody else. There's a staffing shortage. And they have to reach that high threshold, which they can't. So then they do a director's hold, they do safety planning, but pretty soon that person is reintroduced back into the community. And then we're dealing with them minutes afterwards. And this goes on and on and on. Now, they are committing low-level misdemeanor crimes, usually trespass and disorderly conduct. That's the most common ones. Ultimately, we have no choice because we have victims that we have to arrest them. So we arrest them and they go to the jail. So then that person gets a defense attorney who does an assessment, finds out that they're unable to aid and assist in their own defense, and by then, so what happens is then the DA has to drop the charges and they're released back into the community. It's a revolving door, it's a broken system. So to answer your question, we still deal with the same people over many times before they reach that threshold, before they can be involuntarily placed. And do you want to comment on that, Danielle? Is there anything about that?
I agree with what you said, but it's really heartbreaking watching somebody continue to deteriorate like that. We want to be proactive, not as reactive as we have to be. The bar is really high. We've had clients that should have been civilly committed, but they didn't meet the level according to the rules and regulations.
When you say be more proactive, what do you mean by that?
The way we had it back in the early 2000s, where we had availability to help a client or a person get further into their care, like the stabilization on medications or, you know, those types of things. We don't have that any longer. They have to either be voluntary or meet the level of needing to be placed on a hold for acute placement.
Aside from the obvious answer that more money would help, what would right look like? I mean, what would it take for us to get where you're describing right now?
Change in legislative
Yeah.
process. It's more than just money. There needs to be a bigger change.
What do you think we, all of you, could do locally to help the situation? Say legally things don't change, help the situation as it is. What would be like 3 things that we would need to happen? I mean, psychiatric beds.
Yes,
And
psychiatric.
what are like your top 3?
Well, if I was king for a day,
Yeah.
the funding, acute psychiatric, well, let's go back to what it was before 2007. Let's have more money, more bed space, an acute psychiatric center near here, if not here. And here's a fact. You want to get the hospital fired up, you ask them about this, because they only have, they have designated ER rooms for patients suffering from mental health. And a mental health patient can be in that room and take up that room for days, even longer, in some, while the whole process is trying to get them into a longer-term bed space, because there is no bed space at the state hospital available. So if we had more bed space, we had the bar lowered for involuntary placement. But see, these things all happen at the legislative, because we all collaborate, like we all work together, we ask these questions every month at our meetings. What are we not doing that we should be doing? And what are we doing that we shouldn't be doing? In trying to address this and make our community better for everybody involved. And sequential mapping is one of the things that we do. We get the whole state involved, the Oregon Health Authority and GOBI, and we identify where are the gaps, but some of those gaps is in housing. Well, Jason Hayes, I don't have a solution for housing. What the LaGrande Police Department is trying to do is jail diversion. Keep these people from tying up and going to jail when they don't need to be, because they're not criminals. They're committing crimes because of their crisis that they're in. They're not criminals. And the system has made them go into the jails. And I mean, the sheriff can talk about, you know, I'm friends and work closely with the jail commander, Lieutenant Hulter, and his deputies are getting assaulted and injured by mental health people in custody, and not from the other ones, because they don't belong in jail, they belong in a treatment facility.
And the accountability in those circumstances doesn't exist because they were in crisis when they committed the thing they did against the deputy, correct?
Correct, exactly.
So do you work at all with, I mean, do you work closely with like Baker County?
I do not in my scope of care.
You guys,
We do.
you do very,
We use their medical detox and
Okay.
respite quite a bit.
so they do have, I mean, and do they still have treatment beds for,
It's all around the state. That's another thing I do, is I send off referrals to all the facilities that take Medicaid
Right.
for people for long-term inpatient.
right?
But for the detox, it's been harder to get people in. We actually had somebody last week, a staff took somebody over and ended up having to turn around and get them, so they were gone for about 3 hours. That took a staff out of our office,
Right.
and they were too high level for there.
Okay.
So when you get back and this person is houseless and a horrible mental health crisis, what do you do?
Right.
That's one of the things we're seeing a lot of is high acuity for mental health and significant addiction. There's no placements available for that. We have Independence Place in Hines? Is it
I
Hines?
can't remember where those ones are.
Over by Bend.
Okay.
And there's a wait list just to be put on the wait list. They're not taking any names right now.
And that'll be the beds that are held up at the hospital if somebody's on a hold to try to get them into a place.
So have you talked with the hospital about if they can open up another wing or something? I mean, they keep.
They're limited in number of beds.
They're limited and
They're
then,
limited?
yeah, and our hospital won't help with detox. They won't detox.
Okay, that's what I was
people,
gonna
and
ask, because it seems like the
yeah.
hospital should be part of this group.
Yeah, it's just one of those,
Okay,
it's
okay.
limited where
Okay.
the resources we
But they
have.
still have the beds for people who want to go back, they want to get into treatment, alcohol and drug treatment.
Not at the hospital.
No,
No.
Baker.
Mhm.
They had limited beds, I know,
Yes,
but.
yes.
I don't know
So
how
would a
many.
medical detox facility in LeGrand or Union County, would that be a significant game changer?
I believe
Yes.
so.
That-
Absolutely.
Would that be like the number one piece of the
That's-
puzzle to help?
That's what I would say.
'Cause that sounds like that would at least get things started.
Yeah,
I think the detox would be essential, but I also think we need to be able to wrap them up in residential afterwards. Because
Yeah.
you're only gonna get 3 to 7 days in detox.
Yeah.
That's not gonna help somebody who has.
For
years of
drugs, you're
use.
speaking of.
Yeah.
So I know that a lot of the citizens here would have concerns about the point that you made earlier, which is, you said, well, if we do this, it's not like we're gonna be getting people sent in from other communities. We were told the same thing with the warming station, but we've seen factually otherwise. So we've interacted with homeless individuals who were sent specifically to LeGrand because we have a warming station from outside communities. So what's your evidence that this would not lead to people with mental health issues from surrounding communities being put into our community? to
so I
receive
don't
this
have any
service?
evidence, but I do know, like,
Right.
go
So when
ahead.
it comes to the resource station, it's actually not the case.
So I've
and-
talked with individuals who stated their reason for being in LeGrand is because they were told to come here because of a warming station.
Yes, there are
So-
people who have come here, but the majority of the people we work with are from LeGrand and have been here for 5, 10, 20, 30, 40 years and stuff. Because we keep track of every single person who comes through the resource center, and we have done that for like the last 5 to 6 years. We do an intake for everyone, first and last name, where they're from, last four of their socials, and it goes into this system called HMIS that's shared with DHS, Community Connections, CHD, and the Resource Center, and like a few other places. And the majority of the people that we've seen are from here. We do get a few people here and there coming from Pendleton or like, other cities, but the majority are from
The
here.
one I interacted with was sent from the west side of the state over here.
Yeah.
I think
So
that
how-
happened more
It's
when the,
it's interesting.
Weather-
How many people-
weather-wise-
This was recently. This was
oh,
within the last
recently,
because
because I know
we
it
do
happened
about-
when the warming stations
Yeah.
started opening.
And there have been 2 that I've interacted with, I think, within the last year.
So that's
who were
2,
told they
but-
specifically came here. Again, I don't know how that works as a percentage, but.
Well, for a percentage, that's
Right.
less than 5%, because this year we've done 109 individuals so far,
Okay.
and last year was 109. So in terms of how many people we've seen, 2 people out of 100 is like less than 10%.
Do you have data when you take your intake forms as to how many of these people came from other communities? Can you
Oh, yeah,
speak
yeah.
to what that is? Because I imagine it's more than the 2 I spoke to. And one of those represented about 6 individuals, so.
Yeah, so yeah, we keep track of all the data, all the numbers.
And
I can get you
because
this.
I know as I interact with community members, that's a major concern that they have about creating a facility here, is that we then become a target for outside referrals in. And I don't think that's what we want to accomplish. We
Correct.
want to take care of the individuals that are here and make our community better. We do not necessarily have the resources, we would all agree, we don't have the resources for our own individuals. We don't want to become the target for outside individuals being referred.
So I can speak on like the detox and some respite. When we send people over to another community, they do their days in detox and then we coordinate and get them back to their community. So that's
How it's supposed to
if we
work.
got people from Baker or Umatilla, like, they would be going back. It wouldn't be a long term.
I just, for reference, I ran some numbers here. You seized 495 grams of methamphetamine in the last year, is what
Yes.
you said. That is 200 milligrams of the lethal dose. Okay. So that's 2,500 lethal doses of methamphetamine, or about 7 lethal doses per day on average, if you average that out over, daily over the year. If you look at fentanyl, this gets a lot worse. That's over 20,000 lethal doses of fentanyl in the amount that you seized in 1 year. That's more, we could kill our entire community, and then some, right? That's 57 lethal doses a day. This is absolutely insane. I mean, if you just look at those are lethal doses, by the way, that I referenced. Those aren't even the doses of individual, when people use it, they're not trying to use a lethal dose. They're using a smaller amount. But, I mean, this is, again, it's wild. 8,300 to 100,000 doses of methamphetamine on what you would consider like a normal street dose for somebody to use. That's just in our community.
And
This
these,
is huge.
to your point,
huge
these aren't
problem.
even drug dealers that we're seizing these from, for the most part.
Right, these are probably just individuals.
Yeah,
who possess it.
we deal with them on another crime, and this is what they had on their possession.
I think that reinforces how big of a problem this is, but the reason I'm talking about this is because I don't think we're gonna move the needle on housing significantly. We have tried for years, that's not gonna be something we can do. Are we gonna build a mental health treatment center? No. We don't have the resources, we can't even touch that financially. Same with the detox center. Frankly, it's not gonna happen, okay? Barring some federal gift of over $1 million, that doesn't happen. What can we do? We've talked about this. We can move the needle, I think, on prevention. We can start now to act so that 20 years from now, we aren't putting more people into these programs. And then we have talked about a drug task force. That's something I think we can legitimately talk about moving the needle on as a council. Because we can talk till we're blue in the face, but what can we actually do as a council? I think we're limited to those things. I invite the thoughts of others, but I think that's something we can do. Is on the enforcement end, we can provide, we may have resources to fund drug enforcement officers. We may have resources to beef up what we're doing in the schools and with our children to try to deter them from these things.
I think some of what you just said is definitely good for us to strive for. But we have real challenges in the police department, not for lack of strong efforts, but real problems trying to get to staffing level. And so to pull another resource from what we currently have to throw it at the drug task force to make it a focus there, only it makes the current problem harder. It'd be one thing if we find ourselves at a place in time where we are actually at 100% and we could have indicators that show us that we actually could hire 2 additional or 1 additional officer. But the reality of it is it's a whole lot harder to get there than just simply saying throw a resource at it. It actually creates another problem somewhere else if we pull a resource right now and throw it at that answer, even though I would agree we want and need to do it. But we're going to create other problems if we just say we're going to do that right now.
And what's the point of arresting someone if it takes 2 years to even get their case heard, or, I mean, that's...
But we're gonna continue to do that because
Yeah.
it's the right thing to do.
But,
And I think that, I don't want to step
But
on each
then
other,
they-
but
yeah.
the disruption portion of it, if we set the tone out there that don't come to LeGrand because they have a task force, or we're going to disrupt that supply chain to our local area, which in turn will show some huge benefits. There's always gonna be somebody that's gonna step up and take that guy's place, but just taking that person, incarcerating them for the 24 hours or however long it is, removing those drugs from the seat, presents a huge inconvenience on that, it's a cartel ring, but a huge inconvenience on that supply chain to LeGrand. You're 100% correct. And when you said that, we did a study on a stabilization unit, and part of the grant funding that we were looking at applying to required us to have a certain amount of beds for out of state or out of area people coming in. So that is a concern.
but if they're inpatient, then they're not really out in the community, they're being
Agreed.
treated.
Agreed.
So have we approached the hospital or other medical providers on opening a detox facility? Has anyone had
That's why I was saying, I think
discussions
the
there?
hospital should be part of this.
Yeah, I know they can't do it on the hospital
But they
because
could
they're
be part of it.
restricted.
Yeah.
But has that been part of the discussion anywhere?
It has been in different circles. I know that there's an individual that was looking to open a stabilization unit here. Dr. Rice was talking about that
Right.
stuff. So I know that there's other people talking about that. I know there's been some other avenues explored, but I don't know enough to speak on it.
Does the threshold for involuntary committal change if it is in a hospital setting with a staff psychiatrist?
I don't
Or is that
I don't
threshold
think
the
so.
same?
It's still the
for
same.
them?
The state sets the bar, and this is what it. yeah.
We, in our behavioral health MDTs, this comes up, and I don't want to speak on behalf of the hospital and CHD, but it gets kind of heated because there's physician holds, director's holds, and then police officer holds. But to answer your question, that no, they are all under the same state statute, which is governed by the Oregon Health Authority. I don't want to speak too much because it'd be outside my.
That's my understanding too. I work at the hospital, but I don't work on that end of things. But yeah.
When we get together like this, it's frustrating for all of us because we're all grasping for solutions and we hit roadblocks.
Constantly. You're gonna hit those roadblocks all through the state then.
Yeah.
Everybody's probably hitting
Yeah,
them.
oh yeah, this is
So it's not just us that's hitting them.
correct.
I mean, as a community, we need to push for legislative change,
Yes.
but in the meantime, we also have to find some other solutions too.
And we're all in it together.
One thing, a lot of these things that I put on that last page are Band-Aid fixes. But if we were to get this, it's an impact grant through CHD. If that was to come to fruition, we had a community service officer, it would alleviate police officers from what, Chief Bell always called dwell time, is that because the amount of time it takes for officers to de-escalate and mitigate people in crisis is a long time. And so if we had a community service officer that could not only respond instead of a police officer, but also give that person a ride somewhere to respite. Our community service officer could take them to Baker if that's, so that would help, but it's a Band-Aid fix.
But if you get the grant, how long would the grant be good for?
Do you know how long the impact grant, is it 3 years?
I think it's 3 years, but it can be extended.
Yeah, because I think what we're doing right now is we're working on the extension.
Oh, so you have the grant?
So we're trying to reallocate what the purpose of that to maybe include a community service
oh,
officer.
okay. So okay.
Can you explain to us what the difference is between a sworn and a non-sworn officer?
Yes, it's authority. So a non-sworn doesn't have the authority to make arrests or issue criminal citations.
They are still trained as a police officer, or they are not?
Not trained as a police officer. No, our code enforcement officer is a non-sworn position.
Okay.
So,
Are there-
special training, but they don't have the authority to make an arrest or cite in criminal matters.
Would there be any liability to the city potentially in having someone without training out acting on behalf of the police department?
Right, oh, good question. So they would not work for us without training. Police departments are sued for two things. Whatever the action was, is there a policy on it? And if there is, did you train on it? Those are the two things. So we would not send a community service officer out without having the training. This is exploratory, but other cities do have municipal community service officers that are non-sworn. I've received a couple of job descriptions of what they do, but it would be something that we would have to look at when rubber meets the road.
Just like what Eugene has.
They have a cahoots model. They have
They're bigger.
Yeah, and they have a full-time clinician on staff who works for them. This would just be on these things where you're having somebody that you're dealing with over and over and over, but aren't a threat to anybody, is just having a community service officer who's trained in mental health first aid and can be a conduit between them and services.
But if we have a shortage of services, the conduit, I mean,
Yep,
yep, I mean,
yep,
there's an
you see,
issue there.
you see it, yep. But
So, I mean, kind of this, some of it doesn't work very well because you don't have the services for this person to be able to send
Do
these
their-
people
Right.
to. So we're kind of stuck in the same thing, aren't you?
we
To
are,
some
but there's
degree.
some circumstances, then Danielle hit on this, where you strike where the iron's hot.
Okay,
If you get some voluntariness, you get that right now,
okay,
before they have a chance to
too.
change their mind.
But if there's still no service to go to
Yeah.
provide that, so, to take care of that, we're still in the same position, aren't we?
Right,
We
we
are.
need a
Yeah.
detox, we need
I know.
that end of things.
I
The
just think
progress is still being made. Since I've been at the resource center, staying open, especially this season, every single day, we haven't had one closure, which is amazing compared to the last few years. We've seen an increase of people wanting to go to detox, an increase of people who have more stable mental health, because it's really easy to like destabilize when it comes to mental health when you're outside and you can't shower, you have no place to use the restroom and stuff. The resource center not only does a lot of hand holding and helping people that can't help themselves all the time, but just those basic things have been very beneficial in terms of people getting housing. This year we've had 8 people get into housing, and that's about 10% of the people we've seen come through our doors this season. Last season we had about 5 people who've gotten into housing, and that's whether it's an apartment, residential treatment, an Oxford house. But it's been about 8 to 10% each season and stuff, which is really high and stuff.
And how is the retention?
The retention is hard. Last year, we had about 6 people lose their housing and then another 5 keep it. This year with the 8 that are getting to housing, I have high hopes that they'll keep it
Okay.
because they have less struggles than last year's group, but it's all about those wraparound services. With me and Maggie just being us 2, with 100 people that we see, it's hard and stuff.
Okay.
Stretch pretty thin.
Yeah.
So what does the house that's on the corner of Cove and Willow, I believe it is, what do they do there?
Oh, yeah.
That's
The- you had the black
EOCIL,
one? Yeah.
it's EOCIL.
Okay,
They
yeah.
are harm reduction,
They're what?
harm reduction.
So what does that mean?
It's a place to clean needle exchange, to do your drugs safely.
Okay, so they
2
don't,
houses for that? There's 2 buildings.
Yeah, and they also have beds there. It's a new program they just started where they have about 7 or 8 beds
Yeah.
for people who are in active addiction to be able to stay there and stuff. So it's not exactly a detox, but it's a place where people can go when they're in active addiction. We don't turn anyone away if they're actively high or like drunk or anything, but it's nice to have more than one spot for organized services.
so you do send somebody there, you have?
Well, you have to sign up for it and like apply for it and stuff. You just show up and stuff, but there you have to like sign up. But yeah, it's another place where people can
Okay.
not be outside.
Just, I see the building, but I never see anybody there.
I never seen anybody there either.
So I don't know.
It's like
really-
pretty new. This is like within the last 2 or 3 months.
Okay.
So like, I don't think it's officially started yet. I have to talk to Madeline.
Because I know it was an old house and that they remodeled and they
Yeah.
built the other one.
She does a lot of outreach on the streets and camps and getting different resources to people. She'll go and find them, just like some of our team
Okay,
does. We
so-
go out and,
So where's her funding come from? Is it state funded or
I
Don't
don't
oh.
want to speak on that.
Okay,
I'm not
okay.
quite sure.
But they have chapters all across the state. Like they have a branch in Portland.
Oh.
They have them everywhere.
Yeah, I'm surprised that the county is not here too with this. I mean, because this problem is countywide, it's not just LeGrand.
You have the sheriff.
Okay.
We've had several focus group work groups
Okay.
in regards
Okay.
to going forward with stabilization, that type of stuff. We've actually spent, I think, $50,000. We had a company come in and go through all of the grant writing, all of what do we need as far as stabilization, as far as in treatment, staffing, bed numbers, all that stuff. So
Who's we?
But I'm sure grants aren't easy to come by for this, because everybody's going to be applying for them throughout the state, right?
You know, I mean, our opioid funding, it's basically our opioid focus group is it's the one that's done this research
Oh,
on
that,
that.
okay, yes.
And they've had to, yeah.
I was gonna say, we haven't talked about the opioid funding,
Yeah.
the settlement funds that we've had.
Because I thought that money was
Will
to
you remind me
work
the
with
amount of money that we
something.
have, and then it comes in distributions.
Yeah.
Yeah, I believe right now we have in the vicinity of $350,000, but we also have time that we have to use it by. And so if we haven't used a disbursement within, I think it's 5 years of the disbursement, then that gets turned back over. So that's part of the reason why with the stuff that we're going to talk about in the next council meeting, we have tabled some funds to release because we're on the cusp of sending some back. And we found an actual good fit for utilization of it, so.
And do we know how much the county received?
They received similar disbursement amounts.
Yeah, I think it's a little bit more, but not by much.
Okay.
Yeah.
I mean, again, I think as we look at potential long-term solutions, 600,000 doesn't get you very far.
No.
That doesn't get you a detox center. That doesn't get you mental health treatment. It may buy you a few years of an enforcement officer, although, as I recall, I don't think it was a prohibited use as much as it wasn't listed among, it falls in that gray
I
area
think
where
it
you're kind of
did too.
sticking your neck out a little bit.
'Cause I don't
Can you,
think-
can you not?
I didn't think we could use it for a police
Well,
officer.
as I recall, when I read the language, I don't believe it is expressly prohibited as much as it's in that gray area.
Okay.
In our
So-
And there are
revenue,
some counties, there are some cities that are using.
That's
it
what I've
for-
heard, is that
Okay.
others have looked at those.
I've reached out to them and said, hey, how are you doing this? Because my council is a little bit uneasy about doing
Yeah.
this, and their answers are all over the board.
Right.
for this year in our revenue, we have 125,000 from the opioid settlement, and it's a gradual, it diminishes.
Right. I mean,
But I don't know how much we have, that's income, I don't know how much we have.
I thought John said we had 350.
Yeah, there's something about, like, it comes over time.
It
though.
does
It's like
come over
disbursements over
time.
time.
You get a big one at first,
Yeah.
and then it
So
it's
diminishes
also-
over one.
It's also
2 years.
evolving as there's more settlements being
Yeah.
released, so
Yeah.
it keeps growing and extending also. So
And-
it's a moving target, we don't know.
I think we'd all like to see those funds used towards something with longevity, something with a
Right.
lasting impact, although, again, I realize that's a discussion we have targeted for a later date, but I also don't think it's remiss to talk a little bit in this setting, about, what options we would have that would have a more lasting impact than, we can throw a little bit of money for a volunteer here, a program there, but that's not gonna last.
No, it's not.
Um,
It's
yeah.
not
But we have money
sustainable.
and we need to spend it, so I
Right.
think we need to find an appropriate
Use.
place to spend it that's gonna give us the most bang for our buck. That's why I was asking, okay, what do you think would give us the best, the best chance of putting a dent in this at least?
I mean, you almost want to look at like another community or another place that has those resources,
But they're-
that doesn't have them, maxed out. And like jails, other places do this, where you basically throw money at it and say, we're going to pay you to allow us to get, our people in here and get some treatment. That's far more cost effective than trying to build or create
But
something
we
like that
can't
on
do
our
that.
own.
That money isn't large enough to do anything with like that, like building something.
No,
there.
yeah, it's just not,
No.
but that's what I'm wondering, like,
Yeah.
can we look at other resources? Baker's the closest one, I think. It's, but,
Maybe
do you
they
go
can add
across the
to it.
border? Do you look at Idaho? Do you look at Washington? Those may be on the table. If you look at what does it take? What's
Yeah.
the money that it takes to lay claim to,
So many
some
beds.
channel to get people help?
Does Pendleton have one?
I don't
I
think they
believe
do.
their detox is closed right now. I could be wrong. Last I heard their detox was closed, but the residential is open. If you try to go out of state, also you run into the issue of insurance.
Yeah.
Yeah, although
Insurance won't
I'm
pay for
surprised
out-of-state.
how well insurance crosses borders around here, especially Medicaid. Idaho and Washington, Medicaid crosses pretty well for medical care.
It does for medical care, but not for mental
Not for
health.
mental health.
Oh, okay.
Okay, it's a little different than,
So, yeah, I agree with you that, you could get probably more bang if you could say, hey, can we tag into this? You can expand a little bit, maybe even for a couple beds.
I mean, that's the problem with addiction, is until you take care of the addiction, it's
Yeah.
coming back. Or,
And-
you know, until you get somebody stabilized well enough with mental
Yeah,
health,
well, I know
it's
that's
coming
gonna be
back.
9 months or so, 6 months,
Right.
Takes a long time.
to get them stabilized.
I can
Isn't
put
it?
myself on blast and say and then part of what makes me allowed to do my job, I have lived experience with addiction and I have 10 years clean.
Good for you.
Thank you. Sheriff Bowen he was a good support, and at times the fear of the drug task force and, but just knowing that there was those people, and back then it was a lot easier for resources, and the majority of the team that I work with, we all have the lived experience. We're very passionate about it, and it's frustrating to not see us be able to do it when people are ready. We've lost a lot of people.
Good, yeah. But isn't usually takes 6 to 9 months to get them,
Into somewhere?
well, into somewhere too, but that long to be in residence? Is it 6 months generally, isn't it?
Most of the programs now are up to 90 days.
90 days, but
Yeah.
is that really enough?
No.
I didn't think so.
You have to do the aftercare, and you
Yeah,
have to
right.
stay in the therapy, and you have to continue to work on yourself.
Right.
Is
And-
virtual care an option at all in this space? Or is that just not effective or not a
I don't
thing?
think it would be.
So we have virtual care that we're
Maybe
using.
some-
I struggle with that a lot when it comes to addiction because I don't find it as accountable. People will sign on, then they'll turn their cameras off, and then they'll disappear. In person, I feel is a lot better, especially for addiction.
Yeah. You have to build that rapport and
Yeah, I
let them
agree.
build to trust you, and it's a long-term thing.
That's what I thought.
So the organization that we're looking at and considering utilizing is the Union County Safe Communities Coalition. And it's a lot of the stuff that we're talking about here is exactly what that organization is intended to do. So that's where we would be throwing that opioid money, is towards helping make those things happen, that treatment.
But they're not doing the treatment.
No, their facility is offering, it's a partnership that's offering many different treatment options for people, or assistance and support for them that are in addiction.
Okay.
I would like to explore looking
Yeah.
again at the usage of those funds. Because again, I think we were informed a couple of years ago, you can't use it for this and this.
Yeah,
But again,
right.
as I looked at the specific language, most of those are not explicitly stated as much as they state things you can use it for, not necessarily things that you're prohibited against. And so if other communities are doing this,
So
I'd like to know about
Yeah, I
that.
think the biggest function is how do you interpret prevention?
Right.
So if you as a council can say that we in LeGrand say prevention is the disruption of the supply chain in LeGrand.
It's hard to use drugs if you can't get them.
Those drug task force, we've also looked at them, teaching classes, adding to that prevention level of, partnering with, having our drug task force aides go into the schools with our youth and talk to them about it, which we have in the past. But if you put it under that umbrella of prevention, I mean, it's how you interpret it, and at the end of the month, when you send in your report of what they've done, and this is what we spent the money on, this is clearly identified as prevention. And from what I've heard from other counselors and commissioners across the state, it's how you interpret it and how you describe what they're doing. So, Counselor, I'm an advocate for it. I think that we can ethically use that money for that, and back it up with what we're doing. Again, like you said, I mean, holding people accountable, it's not putting them in jail. What it is disrupting the whole organization of what's going on.
I mean, if we removed, over 20,000 lethal doses of fentanyl with non-dedicated, officers working on this, what would it mean if we had somebody who could really go after this and say, we do not want drugs as part of our community?
And I'd be honest with you, our law enforcement consumption of taking those off the street, like you said, has all been, not say we've stumbled upon it, because great cops doing great work, but it hasn't been that they've spent a month on this case tracking this guy coming in and out and that type, because we just don't have the time. We'll call to call without having those dedicated professionals to do the wiretaps, to do the buys, to do the search warrants. You know, it really inhibits our ability to go after the bigger fish, if you will.
But are those ones that you can't, that you stop, are they ones that are waiting for trial?
At times, yeah, for sure.
I mean, so that they're back out on the street doing the same thing again?
Yeah.
I mean, the key is when they have an encounter with law enforcement is to have resources for them at that moment.
For sure. And at times, to be honest with you, I mean, that's the straw that broke the camel's back. You go, okay, I went to jail again for this, I'm done, I need help, I'm gonna go reach out. I'm gonna do
Hit bottom.
that.
Yeah.
Yeah.
I worked in the drug task force for 3 years. It takes a lot. It takes a lot of manpower to do a effective work. It takes a lot of resources. It's not just the people. It's the equipment. We don't even have equipment. Well, what equipment we have is so outdated. It's all technological now and advanced. So we would have to buy new equipment to do that.
What kind of equipment? What kind of equipment?
Body wires is probably one of the biggest ones. We use trackers, which are GPS things to track suspect vehicles. These are all under court, search warrants and court orders and things like that. So there's more than just, to John's point, like Cody and I are like-minded. I've been in the task force, I see the benefits of it. There's an option where, because it was me and the Union County Sheriff's Office, one person that worked together, so it was a two-man team. You're about as good as your informants are good, but we had a really good informant and we made a lot of waves. But what was healthy about that is a lot of the people that we arrested, the low-level dealers, all went into drug court, and it was beneficial for about 70% of them. They did not reoffend while I was in the task force. Doesn't mean they don't use, but as far as being in the trafficking. So it is disruptive. It does sketch them out when you start doing your work, so it'll dry up. But it has to be durable. And one of the things I said in here, so right now today, I'm down 5 officers. What that means is I have 2 vacancies and I have 3 in training. So I have 5 vacancies on patrol right now because the 3 that are in training don't count until they're solo. So for me to staff somebody in a drug task force, I want to get there, and you guys set the priorities for me when it comes to that. But we had testing for a police officer 2 weeks ago. We had 10 applicants, only 5 confirmed to attend, only 1 survived the testing. Was supposed to turn in their pre-employment background investigation to me last Thursday and did not. So I have 0 candidates. And that's the trend nationally with policing.
This effort has been going back since at least 2016. So it's not for lack of effort on their part to do all the right things. It's just the reality of the environment that they're trying to recruit in.
I think we've kind of understand that. That's been going on.
And of course, you wouldn't put a new officer in that track. I mean.
Oh, no, this is, when you're talking about drug investigations, it's advanced police techniques.
Yeah.
But we have people who could fit that role and the new officers. It's not all doom and gloom because like I said, I have 3 in training right now. That's 3 officers in 7 months from now that are going to be covering the shift and they're wonderful. We're doing good things, we're making way on the recruitment and retention, but it does remain a problem. And so I just have if you said you want a drug task force, me and Cody are committed to partnering. We have a good working relationship. I have a good working relationship with the Oregon State Police, and we might be able to pull them in some way. But being able to staff it is a barrier for me right now.
Well, I'm just thinking, if we determined that was an appropriate use of our opioid funds, between us and the county, if we could talk with them cooperatively, you might fund somebody for 5 or 6 years. I mean, that starts to put a dent in things, you know, that's one of many uses, but, you know, I wanna see what we can do, you know, and you know, if you put a dent in it for 5 years and get the word out that LeGrand is not a place to be doing drugs, you're gonna get hammered. You know, maybe that lasts a little bit longer, I don't know, or maybe we scrounge up funding somewhere in the next 5 years to be able to do something, you know, more. Again, I look at our funding options, and to me, again, we talk and talk and talk and talk, and that's fine, but what can we as a council actually do? It's one of the few things as I went through here, and I said, well, we can do that. So, I mean, I'm all ears for other things, but I feel like so many of the other uses for those funds is gonna be a little pittance here and a pittance there, and it's not gonna move the needle.
Stu, could you talk to what Union County Safe Communities Coalition could do?
I think they're gonna make a presentation, is that right, John?
Sorry.
Is the Safe Communities Coalition on the agenda in March?
They will be, yes.
So
Okay,
there'll
so
be
we're
a
gonna get that.
presentation, right?
Oh, I wanted you to do
I could do it, but I wouldn't wanna spoil their,
it. You always do
You wanna do
anyway.
it as well.
How about we let them do their presentation?
You're the boss, right?
Because that's a different kind of option. Yeah.
It's just
And
a change.
Yeah, I don't.
yeah, it's
I don't
it's
have
just
the
a change of mindset, right? Prevention is different than treatment,
Yeah.
but
It
they
is.
go hand in hand, prevention and enforcement, prevention and treatment, I mean, it's
Right.
all puzzle, you know,
It
so
is.
it's complicated. And it all needs more money and funding and resources and legislation and changes, so.
Right.
We do have the advantage of Measure 110 getting kind of back reversed, and that's been a huge help to you guys, I know, with decriminalization and then recriminalization of some of those drugs and substances, but yeah, it's complicated.
It is.
What efforts are League of Oregon Cities tapped into what they're doing with this? I mean, I'm sure, again, we're not in isolation here, but it might be nice to know where we can link in with other communities and lend our voice to, you know, potentially trying to convince our state legislators that what we have isn't working.
Yeah, no, I don't know the answer to that question. It's a good point. I can tell you, I'm looking at the next, what do you call it, conference that's next month. I'm not recalling right now anything that's on the agenda that's specifically addressing it, but I do have access to a overall League of Oregon Cities city managers group that I can pose things like that and bring it up, so I will do so.
Seems to be all about transportation right now, not about drugs and treatment.
Yeah, and the transit room tax and,
Right.
yeah.
Those are Salem issues.
Wish we
right
could have
now.
given you a great answer, but we don't have it either, the solution.
So, this is providing you with just information,
Information,
and
yeah.
you can see the barriers that we struggle, not just as a PD, but all of our constituents here that
It's a
deal with
huge-
these things.
It's a huge barrier.
It is, it's a, yeah.
And we alone cannot fix it, unfortunately. Alone, I mean, this whole group here cannot fix it, unless we had the money,
Yes.
which
Do you ladies get to see a success from individuals that make it through though? There's not another town, another town now.
Yeah. Anybody
But it's
that,
really hard on getting there.
yeah, takes a lot of work. But it makes it that much more rewarding. I
Rewarding,
think.
yeah. You guys have a ton.
We do, but I love it.
Good question, Nick.
You have to have.
Yeah, well, I wanted to point out, you guys are asking about kind of other communities. Umatilla County has a really great program, the PATH Center and Program, where they have a transitional housing center south of the city of Umatilla. And it's a real regional collaboration. They try to provide wraparound services, but they get people there, they kind of, it's very temporary sort of housing. They're kind of like yurts, and the weather there is a little more moderate than it is here. But that's a program they've had a lot of success with over there, and kind of getting people off the streets, getting them somewhere. They've got a navigation center, they call it, where they've got kitchens, they've got professionals that come in and provide these services, and then, you know, the idea is to get them out of that into something more permanent, but it provides a little bit of that kind of in-between services that they need.
It's called a PAP.
PATH, yeah. Project PATH.
We are running towards the end of our meeting here, and I want to say thank you to each and every one of you who dedicated your time and come out here and spoke with us. We had a lot of great information. Of course, we all know we have a lot of work. You know, there's a lot of problems, but solutions are not the easiest way to come to. But we do appreciate you coming out and sharing with us and giving us the information. Before I close, is there any other questions or comments the council would like to make?
I just appreciate you working in the fields you are, because
Thank
not
you.
everybody can do that.
No.
And obviously, there's so many holes that we have, that we can't fill.
Thank you.
Anybody else? With that, I would say thank you and good evening, and we are